Hello and welcome to the COMLEX Instant Review. Let's talk about Farber's disease. This is an autosomal recessive defect in ceramidinase causing accumulation of ceramide in the nerves, and its onset is usually months after birth, and the death usually occurs at years 2. Now, what is Felty syndrome? That's rheumatoid arthritis, splenomegaly plus neutropenia, and it's often seen with thrombocytopenia. So it's important to know the definitions of certain syndromes just because they may have them as an answer choice. What is fibrolamellar carcinoma? This is a variant of hepatocellular carcinoma that occurs in younger age people, and it's not associated with any viral hepatitis or cirrhosis. It has a good prognosis, and histologically you'll see nests and cords of malignant hepatocytes that are separated by dense collagen bundles. But again, the key association here is hepatocellular carcinoma. Now, let's talk about galactosemia. What is galactosemia? Patients who have galactosemia have failure to thrive, infantile cataracts, mental retardation, and cirrhosis. So there's a deficiency of galactose 1-phosphate uridyl transferase, which blocks galactose conversion to glucose, and so there's no further metabolism. It's rarely due to galactokinase deficiency, and again, understand that patients who have cataracts as infants along with cirrhosis, mental retardations, and failure to thrive, you're going to think of galactosemia. The boards will want you to know the name of the enzyme, and so it's important to know that galactose 1-phosphate uridyl transferase is the enzyme in this condition. What is Fitzhugh-Curtis syndrome? This is an association with chlamydia or gonorrhea in patients who have perihepatitis as a complication of PID. So the classic scenario is a patient who has had PID and then they develop right upper quadrant pain and sepsis, and then you're going to think about an infection such as chlamydia or gonorrhea as a perihepatitis. So Fitzhugh-Curtis syndrome, PID, leading to right upper quadrant pain and sepsis caused by chlamydia or gonorrhea as a complication of PID. Now, what is Gardner syndrome? This is an important topic because it's very high yield. It's a triad of desmoid tumors, osteomas, and mandible osteomas, as well as skull osteomas and sebaceous cysts. So the three things again is desmoid tumors. Secondly, it's osteoma, so the mandible or skull, and the third is sebaceous cysts. It's a familial polyposis syndrome, and typically on the board exam, if a person comes in with this condition early on, then the treatment options are going to be something where you want to make the diagnosis quickly. Now, what is hepatorenal syndrome? This is basically a condition where patients have renal failure without intrinsic renal disease, and it's occurring during fulminant hepatitis or cirrhosis and presents with acute oliguria and azotemia. So in a patient who has acutely developed oliguria and azotemia along with some kind of a hepatitis or cirrhosis occurring at the same time with renal failure, but they don't have intrinsic renal failure, so it's probably a pre-renal or post-renal type of a condition. And those three things together considered to be hepatorenal syndrome. So you have some of the hepatocytes involved, such as the fulminant hepatitis and cirrhosis, along with the renal, the kidneys involved, where you have renal failure, and oliguria and azotemia. So those are the key features of hepatorenal syndrome. Now, what is Hartnupp's disease? Well, this is an autosomal recessive disease in tryptophan absorption. With a lot of these syndromes on the boards, it's important to just remember the amino acids or the enzymes to help you narrow down the answer choice. And again, the symptoms here can mimic pellagra, so you can have dermatitis, dementia, and diarrhea because tryptophan is niacin precursor. And there's a rash which is on sun-exposed areas, and you can see cerebral ataxia, mental retardation, as well as psychosis. So the 3Ds plus the mental retardation, ataxia, and the psychosis, and the treatment is going to be niacin supplements as the answer choice on the board exam. Now, what is Glanzmann's thrombasthenia? Well, this is a autosomal recessive defect in G2B3A platelet precursor. And again, what happens here is that G2B3A usually binds to fibrinogen, and here you have autosomal recessive defect in that. And there's inhibition of the platelet aggregation, so this usually presents with chronic severe mucosal bleeds. And the other condition similar to this is autosomal recessive defect of platelet GP1B, which is Bernard-Soulier syndrome. And that binds to von Willebrand's factor, and it presents with chronic severe mucosal bleeds and giant platelets. So there's a big difference here in that here you're having inhibition of platelet aggregation due to the GP2-3A platelet receptor in Glanzmann's thrombocytopenia. Now, what is Gaucher's disease? This is a condition where patients typically present with a lysosomal enzyme deficiency. It's autosomal recessive, and the beta-glucocerebrosidase is deficient. There's an accumulation of sphingolipids in the liver, spleen, and bone marrow. And again, it's common in Ashkenazi Jews, and it can be fatal if the enzyme substitute is not administered, which is the L-glucarase. Okay, so on the board exam, remember, if you see an increase in sphingolipids, and a deficiency of the beta-glucocerebrosidase with a lysosomal enzyme deficiency, you're going to be thinking of Gaucher's disease as one of the key answer choices. What about the genetic defects in metabolic enzymes causing glycogen accumulation? Well, these patients have hepatosplenomegaly, generalized organomegaly, some sort of exertional dyspnea, and hypoglycemia. And those four things are common amongst the different types. Type 1 is von Gerge's, type 2 is Pompey's, type 3 is Cory's disease, and type 5 is McArdle's disease. And it's important to keep in mind just the general presentation: hepatomegaly, general organomegaly, exertional dyspnea, and also hypoglycemia as the main things that you'll see. Now I want to talk about hepatopulmonary syndrome. We had talked about hepatorenal syndrome, which is fairly simple, in which patients had both renal and hepatic disease. Well, here you see developmental arteriovenous malformations, which are usually intrapulmonary in the setting of cirrhosis. So there's that hepato component. And again, in the pulmonary component, you have AVMs, arteriovenous malformations. So cirrhosis plus AVMs that usually causes pulmonary shunting with severe refractory hypoxia. And patients usually present with platypnea, which is dyspnea when standing, that improves with lying down. That's a key thing you want to look for on the boards. The pathophysiology of the AVM formation in the setting of cirrhosis is not quite well understood, but the only transplant treatment here is going to be a liver transplant. Okay, and that can cause regression of the AVM. So be careful. Even though this is a hepatopulmonary syndrome, the key thing you want to fix is the liver conditions here. And so the key factors you want to focus on the board exam is patient with hypoxia, with cirrhosis, and intrapulmonary AV malformations, along with that sign where they have improvement of the dyspnea with lying down. In those patients, you're thinking of hepatopulmonary syndrome, and they require liver transplant. That was a podcast for the COMLEX Instant Review. Please visit comlexflashcards.com for additional board review lectures, and good luck in your preparation for the boards.